This is The Rounds Table. All right, welcome back, listeners. This is going to be a solo episode, and it will not be a randomized trial. No, we're breaking from the script. This is a meta-analysis, and the meta-analysis was entitled Evaluating the Risk and Benefit of Continuing versus Withholding RAS Inhibitors, a systematic review and meta-analysis, published in BJA Open. I have never heard of that journal before, and published in 2025. So the background here, as many listeners will know, half of patients who are undergoing elective surgery have high blood pressure. Many of these patients will be on an ACE or an ARB, and we know that just in general, patients with high blood pressure are at a higher risk of post-operative complications. Some of these complications relate to medications. So with ACE inhibitors or ARBs, the typical teaching is that they should be held prior to surgery. And the thought is that, it will reduce the risk of post-op AKI and also maybe, reduce the risk of low blood pressure after the surgery. But mainly, the main reason why it gets held is this idea is that it might increase the risk of acute kidney injury if it gets continued. If you rewind the clock a few years, there were really no randomized trials, and most of the data was from expert opinion and observational studies. Over the past few years, there have been multiple randomized trials, and that, of course, sets the stage for a meta-analysis. The one last thing I'll mention, and this is what the authors bring up in the introduction, is that there are conflicting guidelines. So the Canadian Cardiovascular Society generally recommends holding ACE inhibitor or ARB at least 24 hours before surgery. The 2024 American Heart Association guidelines recommend withdrawal of ACE inhibitor ARB before surgery. They say it really to reduce intraoperative hypotension. And the most recent 2024 European Society of Cardiology guidelines don't actually provide a definitive recommendation one way or the other. So let's just see what the data show. So in terms of the methods, the authors followed the PRISMA, which is a preferred reporting items for systematic review and meta-analysis guidelines when putting together this study. They searched studies up until the fall of 2024 from PubMed, Scopus, Web of Science, Cochrane database, to name just a few. They included English language studies. It had to be an RCT, and the RCT had to compare either continuing or holding RAS inhibitor before non-cardiac surgery in adult patients over 18. Some of the outcomes that they collected and assessed were post-op cardiovascular outcomes, all-cause mortality, AKI, post-op infections, intra-op hypotension, post-op hypertension, to name just a few. They excluded observational studies, which makes sense to me. The statistics, I don't want to bore you guys to death with that, but in general, they used the random effects meta-analysis, which is a pretty reasonable approach. And for data collection, they had multiple people independently review the data. So what did they find? Overall, there were 6,700 articles that met inclusion criteria. That is a lot of articles to review. After they screened primarily the titles and abstracts, they excluded the vast majority of the studies. In the end, they were left with 7 randomized trials that enrolled just under 9,000 patients. And again, half had their treatment withheld before surgery and half had it continued before surgery. Regarding the timing, it was a little bit different across the different studies. One study stopped ACE inhibitors at least 24 hours before. 4 studies withheld the therapy the night or day before. And one study withheld it at least 48 hours before surgery. The individual studies themselves, I'll hit you with the high points. There were a few really large studies here. So one example was POISE-3, which had just over 5,000 patients. Legrand and colleagues in 2024, which is published in JAMA, had like 2,200 patients. The typical age was sort of in the 40s to 50s. Most studies had a predominance of men, anywhere from, approximately 60%. Almost everyone across the studies had high blood pressure, and coronary disease ranged from 10% to closer to 30%, depending on the study. Most studies had 30-day follow-up period. Some were a little bit shorter than that. So what did they actually find? Well, in terms of cardiovascular complications, there was no difference between the two groups, with a relative risk of 0.94 going from 0.79 to 1.12. In terms of acute kidney injury, no significant difference in AKI, relative risk of 0.95 with interval ranging from 0.84 to 1.06. Other outcomes that they looked at as well, mortality, no difference, relative risk of 1.16 with confidence intervals ranging from 0.55 to 2.43. Post-op infection, no difference. Intra-op hypotension, there was a difference here. So if you continued on the ACE inhibitor ARB, you are much more likely to have intra-op hypotension, and that was a relative risk of like 1.3 with confidence intervals that excluded the null. Post-operative hypotension, the results weren't a slam dunk, but it suggested likely more post-op hypotension if you continued your ACE or ARB. In terms of post-op hypertension, a slight signal towards a bit of post-op hypertension if you did not continue your ACE or ARB, which of course makes sense. They also looked at length of stay, which didn't differ between the two groups. So, there you have it. This is the best available data we have right now in terms of whether or not ACEs or ARBs should be held before non-cardiac surgery. And I guess it kind of depends on what you're hoping to optimize. If you're the anesthetist, it's probably a real hassle when there's intraoperative hypotension. So an anesthetist will probably say, listen, stop that drug at least 24 hours beforehand because that will make their life easier. On my end, it's kind of like, I don't know, intra-op hypotension by itself, that feels like a surrogate outcome, if anything. I'm very reassured by the fact that post-op AKI, no difference between the two groups. So really, I don't have strong feelings, and I think we have data probably which could push you towards one decision or the other, and very useful to have this conversation with your patient. But I think probably gone are the days where we just assume everyone's ACE or ARB should be stopped before non-cardiac surgery. Clearly, the randomized trials show, at least if you were doing that to prevent a post-op AKI, probably didn't make a lick of difference. Very curious to hear from colleagues that do more perioperative medicine than I. How does this affect your practice? What's your current approach given these trials? Overall, it's just great to see more clinical trials in the perioperative space. I feel as though for a long period of time, people are just sort of making it up, and I think it's far more useful to randomize patients and really generate higher quality data to help us inform care. That's it for today. Briefly, good stuff. NotebookLM, a really cool tool made by Google. No, they don't sponsor us, but yes, Google, we would be delighted to have you as a sponsor. NotebookLM is just a really neat use case for AI. It's free. And what you do is you have your PDF or whatever, you drag it into NotebookLM. It now creates a chatbot for that PDF. You could ask it questions and also turns it into an audio summary. And it's like two human-sounding voices. They're bots, but they kind of sound like humans discussing it. So sometimes I do use it, not to generate what you're listening to right now, but instead a new guideline came out, drop it in NotebookLM, and I will much rather listen to these two bots talk about the guideline as opposed to reading a 200-page document. All right, listeners, that's it. Stay well and join us again next time on The Rounds Table.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.